Okay, so everyone, it's Melissa here from Mommy Berries. And again, my goal is to help women understand, kind of how their muscles play a role in preparing for birth and postpartum recovery. And I'm happy to have Dr. Hardave Gill here. Thank you for being here, Dave.
You're welcome, Melissa. Happy to be
He,
here.
yeah, he's from anesthesiology at the hospital in the community I live in, Kelowna. And I really wanted to be able to talk with him or to be able to kind of shed some light on how this relates to what I teach women. And if I just preface it really quickly, I go over a lot of education about the muscles involved in birth and how you're not weird if you don't feel connected to your pelvic floor or some of your breathing muscles that affect your pelvic floor, because we're not really wired to have to think about them, but we do have control over them. And so being able to learn how to relax the muscles involved in a vaginal birth can be really helpful in making it easier for a baby to come out. And a lot of times the prep is, very helpful to women, but often they have the question like, what if I have an epidural? What's that going to do? Is that going to kind of take away all this prep that I've done? And does that change everything? And my answer is usually no, not necessarily. And so that's why I thought Dave, that he'd come here. Luckily, we both snuck away after putting our kids to bed. Probably the last thing you want to do after a long day, Dave. But we'll keep it short and sweet. And so again, thanks for being here.
Yeah, no problem.
Will you start by telling me, like, is epidural use like increasing overall, or like what's the trend?
Yeah, it's a good question. And if you take all of the teaching institutes and the largest hospitals across Canada, for British Columbia, it would be women's and children's along the way, and then you would just go through every province along the way. The epidural rate in all of the large facilities and teaching institutes in Canada is close to about 75%. So 3 out of 4 women will have an epidural during their delivery of their baby along the way. And if you extract that and go to smaller centers, the rate is approaching close to 2 out of 3 women, so closer to 66% along the way.
Wow.
So the numbers, yeah, they haven't really changed all that much, to tell you the truth. They're up or down by 1 or 2%, but they've always stayed in that sort of high degree for the majority of the larger centers. The numbers for the smaller institutes are actually increasing. And whether that's just related to more people moving either from bigger centers to smaller areas and they've had an epidural before, or if there's actually ability to provide epidural coverage in these smaller centers. So most of the big centers are serviced by anesthesiologists that have done like the 5-year residency. So we call them kind of the Royal College anesthetists, and smaller centers have GP anesthetists that have done 1 year of the 5-year training along the way. Realistically, they're there to allow women to have C-sections in an emergency and to provide labor analgesia, or potentially do some small type of surgeries in those centers. So the numbers are up a little bit. BC has the smallest proportion of women getting epidurals. That's at large centers and in smaller centers. Kelowna's, we don't have the exact numbers of where we sit, but we're thinking probably close to about 40 to 50% along the way. And that's come up from closer to 35% about 5 years ago. That data we do have.
Wow, I didn't know it was that high.
And even higher in some places.
So what happens, like, let's say chain of events, like a mom decides that she wants to have an epidural.
Yeah.
You get paged.
Yeah.
And I guess, like, in my head, like, you hear a lot about are they going to be available to come, or, what does that look like? Is there always someone available? Or I'm sure it depends on the center. Like, can you speak a bit to like, what's the sequence once you get paged to you getting there? Or, could there be other places you have to be?
Yeah, no, I definitely understand what you're getting at here, and it's been kind of hot on the press too a little bit. So every site will be specific in terms of their coverage of the obstetrics floor. All of the large centers have designated anesthesia coverage 24/7. So there's at least 1 or 2 anesthesiologists that are present at all times to be able to offer labor analgesia, provide anesthetic services for emergency C-sections, provide assessment and resuscitation if needed, etc. along the way. But there's 24-hour coverage, and you may even have residents to complement on top of that. So that's one of the reasons that the large training institutes, their epidural rates are so high, because at any point in time, there's always usually somebody available to be able to provide the service if requested. So that goes favorably in that situation. When you start talking about the smaller centers, they're not 100% covered. Kelowna does not have designated obstetrics coverage, but we have designated anesthesia services at the hospital. We have either at all times 2 or 3 people readily available. So if one person who gets the initial page is either in the OR providing services elsewhere, we have 2 other layers of backup behind that. So the rule that's in place in Kelowna is if a woman requests, it's in labor, requests an epidural, somebody will be present within 45 minutes, and you should have labor analgesia installed by an hour. So we don't make anybody wait an hour. And to tell you the truth, it almost never gets there along the way. Within about 15, 20 minutes, we know if we're busy and if we have to call somebody in. So it's really just them coming from home and getting to the hospital and upstairs into the obstetrics ward. So maybe half hour at most, but most of us also live within about 15 minutes to the hospital is also kind of our unwritten rule along the way. So not too far off. It's usually about 15 to 30 minutes before somebody can get there.
Wow. And then what would make you say, like, let's say you arrive in the room, like what would make you say no?
Yeah, good question.
No.
Yes, yeah. So there are actually some indications that would basically not allow us to place an epidural. The biggest things in relation to pregnancy that come up are women who've had concerns with high blood pressure. And you can develop syndromes with that. Preeclampsia is a fancy name. HELP syndrome is another one. They're more or less themselves together, but it just makes an individual's blood more likely to bleed. And as we put an epidural in, it does involve us transversing layers from the back to the epidural space. And we can always potentially hit a blood vessel that we can't see along the way. So your body has to be able to clot that off in a safe fashion, or otherwise we can't do it, because the repercussions can be quite large. So women will have their blood work checked throughout pregnancy, and they'll also have it checked when they arrive to the hospital to make sure that all of the numbers that we're concerned of are within normal limits. So that's one thing that we look for. And if the numbers are off or deranged, then we have to do further investigations and weigh the pros versus the cons. We touched on this a little bit earlier. Usually it's a progression of things. Usually there's non-interventional modalities that women will entertain initially for labor analgesia, and it's a progression in terms of using certain adjuncts, whether it's breathing techniques, the ball. Some people use water baths. Some people just have their own sort of plan in place, and that's totally fine. We encourage that. We love all of that to even complement the epidural. It's not a big deal for us. And then it moves through a trajectory. Usually they'll have IV or IM medications along the way if those initial sort of interventions are not adequate to provide the relief or analgesia that the mom is expecting. And then there's nitrous that's available as an option. And then there's interventional techniques, which involves us. The most effective of them, if you ask women who've had children, by their satisfaction ratings, would be labor epidurals. There's no other modality that will give you the same patient satisfaction in terms of them scoring pain relief. And that you can't argue with, because it actually provides pain relief. But that doesn't mean women who don't get epidurals aren't capable of delivering babies. It's a different experience. They themselves deal with the pain differently than a labor epidural does, which tries to steal the pain in full. So they're a little bit different in terms of how they work. In terms of saying you no to a certain individual, basically bleeding is the first thing I mentioned. If somebody ever had an infection in the area that we're going to place the epidural, we don't also try that. And then there are anatomical, like central nervous system lesions. Basically, that's the brain and spinal cord. If there's any anatomic lesions in there that capture our attention, again, we'll usually hold off and use secondary measures to provide labor analgesia. And those are the big three that come to mind for us in terms of when you would say no. There's always subjective things also, depending on how far along a patient is in their labor progression, if it's their first or second or third or fourth babies along the way, that also changes things a little bit, because once the progression of labor has come to either being fully dilated or getting close to pushing, the labor epidurals aren't as effective, and it's one of the questions we'll get to. They take about 15 minutes to start working from the time we insert them. So there's also a time sensitive sort of component to that question. It's not a hard no, but we just kind of take it in context and then talk to the mom and see what their thoughts are. If they think it's worthwhile, we can do it, and if not, we can usually hang out and sort of just maybe give it a bit more time to see how things progress along. Go ahead.
Sorry, I was going to say, like, how does that fit in with, because I'm again, when I was reading through, like, kind of educating myself to prepare for this, like, I know there's different like types of epidurals, and I definitely got the impression that it would kind of be like physician specific too. But like, you hear a lot about walking epidurals, or that some epidurals are patient controlled. And so I guess I wonder, like, do women have a say in that, or like, what's the difference? Is it simply like turning the dose up like takes away the chance of them having like motor control or able to walk or whatever? Yeah.
Yeah, no, good question. Good question. So it's come up, and the walking epidural is just a vogue name. It started with heavy concentrations of local anesthetic. All epidurals involve a local anesthetic and usually a painkiller combined. And that's the solution that we use. And basically what an epidural is, epi is just Latin for sitting on top of, dura is a layer that basically lines the spinal column itself. So the catheter goes and sits on top of this layer that lines the spinal column. And what the catheter does is it goes up and it freezes the nerves of the uterus. So as Melissa said, the pelvic floor is left alone. The sacral innervation to the pelvic floor is not nearly as well captured as the uterine innervation. Uterine innervation is basically done kind of in the mid-lower back, lower than the level of the spinal column. And the epidural catheter, we aim to put right in that area, so you freeze the nerves of the uterus. And as the uterus contracts and the body would sense pain, that gets frozen. The signals are halted, and they won't go upstairs into your brain and tell you you're feeling pain. So that's the point of the epidural. And how does it fit into the question? We used to use very dense local anesthetic solution that we would try to freeze all the nerves in the area. And very dense local anesthetic solution will give you both a sensory block, which a woman wants. She doesn't want to be able to feel the sensation of the uterus contracting down and the pain that's associated with that. But then you also gained a motor block at the dense local anesthetic solutions. And the motor block is what would make your legs sometimes feel heavy or weak, and you couldn't walk around with those because you'd risk mom potentially having a fall. So what have we done over time? We've just naturally decreased the strength of our solution to try only get a sensory block and leave all the motor nerves fully functional. So the walking epidural came from that experiment on its own, where it was an anesthesiologist, actually BC Children's is where the name was sort of created. And what he'd done is just decrease the local anesthetic solution to a point where mothers were still providing very similar satisfaction scores, yet there was no motor block. So it's a very common solution. It is present at the Kelowna Hospital. It's probably present at every hospital in Canada. And it's just a degree of the strength. So it's there. It's meant to just basically freeze the sensory innervation and leave all motor nerves alone.
And is that why, that's probably why you get like variations between different moms, right? Is that, like, again, we're all individuals. And so like, you wouldn't necessarily have the exact same effect on every single woman with your measured dose or whatever, right?
Yeah, of course.
Yeah.
There's sometimes anatomical changes also in the epidural space that account for those things, depending where a catheter is, etc. And everybody's perception, pain is a subjective that's an experience along the way. So everybody will perceive it differently along the way. And the second thing is, how is it decided? So a couple of things go into that equation. Majority of centers, when a mom is in active labor and at least 3 centimeters dilated, the mom will be admitted to hospital. Certain hospitals have different criteria along the way. Once you've got commitment to labor along the way, then in terms of your progression, whether it's in hospital or at home, that will vary. In terms of our local anesthetic solution, if a mom is 10 centimeters and has been extremely painful and had a progressive labor over 2 to 3 days, she might not want to walk. She might want a dense block where she can sleep for an hour or two and basically kind of at least have a bit of time to get some rest before she has to go through the pushing stage and have her baby, because you don't get a lot of sleep after that. So part of the equation is we usually we offer it as an option. So I usually tell moms that there's multiple solutions we can use. If you're keen to walk around and move around with this, we can start with the lightest solution. It should be enough to make things comfortable that you can sleep and text along the way. If you want even a denser block, or if that isn't up to your satisfaction, we just change our solution. So you can always start with the lightest solution and work up if you feel like it's not providing the relief that you expected along the way. With the only caveat is the denser you go in the solutions, the harder it is, and sometimes the little bit more challenging it is to move your legs. Mm-hmm. So it depends on how the day's going, depends on what mom wants, etc. along the way, but they're both readily available. The walking epidural is just a lighter solution of our local anesthetic, but we also do have heavier options, which we can change very quickly.
And so when someone elects to have an epidural, there's some other things that kind of would go along with that though, right? Like they would need to be monitored in different ways. Like kind of what other tubes or what other things need to be attached or come along for the ride, I guess. Yeah.
Okay. Yeah, no, good question. Again, it's going to be site specific. So the epidural really only comes with a little tubing that goes into the epidural space. It gets taped onto your back. It's not sutured. There's really just tape that holds it in, and then it gets taped up behind your back and usually comes up over top of your shoulder. And then it connects up to a pump. And I know this was one of the sort of topics that was there. The pump itself will naturally just infuse a certain amount of local anesthetic over an hour. Majority of centers, including Kelowna, have come to sort of a combination technique where the pump delivers a baseline and the mom gets to decide if she wants more on top of that. So we call it PCEA as a fancy acronym. Basically, it's just patient-controlled epidural analgesia. We set a baseline, which we think should work for the majority of women. If a woman feels that she wants to have a little bit more pain control, she just presses a button and it adds extra local anesthetic into the space. And 5-10 minutes from then, that the amount of labor analgesia would increase. So again, it just gives mom the control of being able to decide how much of the local anesthetic solution she wants and sort of the effect that she's getting from it. The heavier we go in our solutions along the way, it depends if a mom can get up and walk or go to the bathroom, because no extra tubing, like Foley catheters is usually what most people would think of. They're not required. The only time you need them is when if either a woman doesn't want to get up and go to the bathroom or go pee. Usually I just ask everybody to go pee before I do the epidural if they're able to, just so it's a non-issue from that point in time. If you take the walking epidural solution, obviously you can walk around. So you can go to the bathroom if you choose. But if you have one of our dense solutions and if the bladder is distended, then you may have a Foley catheter. And then there's two options. One is an in and out, which most facilities would do. It's just to empty the bladder with a single catheter, take everything out, nothing left behind. And the second option is to have an indwelling Foley catheter that would just sit in the bladder itself and just drain all the urine as labor progresses along. You don't want a full bladder just because baby's head's got to come in through the canal, and a full bladder would obstruct that passage along the way. So that would be the only real tubing that would come into play. Monitoring is the second aspect that comes into play. When we put an epidural solution in, it freezes the nerves of the uterus. Natural pain relief will drop everybody's blood pressure. Pain on its own will raise blood pressure for moms. So the first 20 minutes, we'll monitor the blood pressure every 5 minutes to make sure that there's not a large change in blood pressure. Usually it changes by about 10 to 15%. It'll go down. As moms stop feeling the pain, they tend to relax, whether they're falling asleep or doing whatever they want. It's just not as painful as it was before the epidural was in place. So we just keep a close eye on the blood pressure to make sure it doesn't change more than that. And then we also monitor baby in that first 20 minutes. So it involves 4 blood pressures, monitoring the baby in the first 20 minutes to make sure that the baby's happy with the epidural and that mom is happy with the epidural.
Okay. And then too, Dave, like you insert, this is one question I had from someone and I didn't know the answer, but you insert the epidural during a contraction, correct?
At any point.
Okay.
It takes us about 10 minutes. So we would get called. We would come talk to mom, make sure that it's in mom's best interest and that it's going to be helpful for mom. When we do it, it's done in a sitting position. It takes less than that. It takes about 2 minutes to do, but the prep is about 5 minutes. We have to use cold cleaning prep on the back. Then we put a little bit of freezing on the back so mom wouldn't feel anything. And then it should just be pressure that mom would feel in the lower back in the center. And it doesn't matter if a contraction comes or goes. Naturally, it'll take us about 10 minutes from the time we get in there. We have mom sitting. Almost every mom will have a contraction in those 10 minutes. So it doesn't have to be at any point in time, whether mom's having a contraction or not having a contraction. It doesn't affect us too much, but we just need mom a little bit more still than not at one point in time as we put our catheter in. So at that point in time, we usually hope that there's no contraction, and we try to time that as we find that space in between contractions.
Awesome. I find that helpful. I definitely learned some things from there. And I think like I wanted to be able to people to be able to picture the process, but then again, also understand that even if you're having an intervention or, having some pain control that's helping you feel less, I always say they don't switch the holes on you. Like the baby's still coming out of the same place. And the more you kind of understand how to control and allow relaxation of those muscles, the easier it is for baby to come out. One last really important question. I don't know if you'll know how to answer this hard one, Dave. Mm-hmm. If you were going to have a baby, would you have an epidural?
Yeah, totally hard question. It's going to be such a biased opinion. It'd have to see how things were going. I think a mom knows pretty early if they're going to need one or not. We usually tell people when we do the prenatal classes, come in with a multimodal plan. Do not rely on one plan. If you think that your labor is going to progress along and be perfect according to a single plan, disappointment, unfortunately, is the only thing that's in your future. Nothing goes perfectly as planned for a majority of women having a baby. So you're going to have a lot of time to think through this. You should just know your options. What's in the toolbox? What can I try? From the time you start having contractions, you'll know how your body deals with it. Everybody's anatomy is a little bit different. Everybody's sort of perception of pain is going to be different, and the degree of analgesia required is going to be different. So you have to kind of put all of those things together and see how you do. If I was not having success, or if I found it overwhelming amount of discomfort early on in the labor, while you're still 3, 4, 5, 6 centimeters along the way, the average dilation is 1 centimeter an hour for mom in the first delivery. So if it's your first vaginal baby, the textbook answers, you're going to go usually progressing forward by 1 centimeter an hour. You have 5 hours to kind of go from 3 centimeters to 8 centimeters. In that time frame, you will know. Contractions they're contracting. They obviously are hurtful to a certain degree. It's something brand new for the body. And if you're finding that the initial sort of modalities you were going to try are not helpful, then an epidural is not something to shy away from. So I would be very quick to change along my progression if I found that the first adjuncts that I was going to try, whatever it be for you, were not successful. An epidural is by far the most effective method for labor analgesia, and it's the safest that you've got. It doesn't interfere with anything that Melissa is saying. A woman with an epidural is still going to have to push. You're still going to have to control everything, and you still have to be involved in the delivery of your baby. An epidural just makes it much more peaceful. It doesn't slow labor down. It really just helps everything in terms of there's fewer tears along the way. There's much more control because you're not feeling the burden of pain to get baby out. It's a very painful procedure for a lot of women to have a baby. And once you get to the point of pushing, etc., to have control, it provides the body a lot more time to relax the pelvic floor, to relax just the progression of your baby and push appropriately. It's when moms have an extreme amount of pain and they're not able to have control of their pushing that leads to larger tears and sort of more negative outcomes to the pelvic floor. So it's used in combination with everything else involved. Again, its purpose is to freeze the nerves of the uterus. And as long as it does that, it's doing its job. You still have to be participating the rest of the way through. So if it was me, I would have a plan. I would have sort of my plan A, plan B type of idea, and just recognize that it's sort of a fluid movement. And if you feel like you're not having a lot of relief, or at least sort of meeting the expectations you had in your mind, I would happily move to an epidural. It's very safe, no detriment to mom or babe along the way, doesn't slow down labor, and the risks to mom are extremely tiny.
Awesome. Thank you so much, Dave. I really do appreciate your time. And I'm looking forward to segueing into a discussion with a midwife in town here who's going to tie in now, like what that looks on the other end for her, and in terms of like what that looks like to assist the mom actually having the baby after an epidural. So thank you so much for your time. Super helpful.
Yeah, my pleasure, Melissa.